Hello, everyone. This week we're talking about respiratory. So we have some objectives here. So the first thing we have to talk about is the functions of the respiratory system. So there's two functions. They do go hand in hand. They work together, but they're not synonymous. They're not the same thing. So first of all, there's ventilation, and ventilation is the mechanical movement of air into and out of the lungs. That's just simply moving air in, air out. That's it. Respiration, though, is actually the exchange of gases in the cellular level. So remember, we talked about the Krebs cycle and that cellular metabolism. It requires oxygen to get energy. So you must breathe in oxygen. That goes then in the Krebs cycle to make energy, but the byproduct of that is CO2. So CO2 then needs to be removed from the body because our CO2 is what is our drive to breathe. So as your CO2 goes up, you breathe faster to get rid of it. You breathe deeper to get rid of it. So that is your drive to breathe. And to know if we are ventilating appropriately, we have to know if the respirations are doing what it should. Do we have good gas exchange? And the only way to know if you have good gas exchange is to measure their blood gases. So we must take a blood sample, preferably arterial. Arterial will give us the best reading of the oxygen levels in the blood. If you do a venous gas, it's blood that is returning to the heart, so it's unoxygenated. It's bringing the CO2 back to the heart, so the CO2 will look a little bit more elevated than what a arterial will, but the oxygen will be very low in it. If you do a capillary gas, the capillary gas will be more similar to the CO2 on a arterial gas. It's capillary, it's the mixing of arterial and venous blood, but your PO2 is going to be low because you've got some of that venous blood in there as well. So preferably an arterial gas is the best way to know if you have good respiration. Some measurements for ventilation. This is just to help you out in case, you're in pulmonology or, you know, just wanting some measurements, lung function, how well is the actual muscles working. The tidal volume is the amount of air that moves in and out of the lungs in each respiratory cycle. So each time you breathe in and out, what's the tidal volume? What's the amount of air that you are moving? A minute volume, you multiply the respiratory rate. So how many times are you moving air in and out? And you multiply that by the volume of air in each breath, and that will tell you your minute volume. So you'll multiply those two. I time is the amount of time for inspirations, and this is very important. You know that the exhalation is going to take longer than the inhalation, and so you want to make sure that you have plenty of time to breathe in to fill the lungs so then you can exhale. If your I time is really, really short, then you're just panting and you're not going to be able to fill the lungs appropriately. If the I time is too long, then you can't exhale right after the as well because you have limited time before you're going to have another inhalation. So the I time is that time that you take to breathe in. The PIP is the peak inspiratory pressure. This is the amount of pressure that goes into the lungs and opens up the lungs. Um, it is pressure, not volume. So remember, we have tidal volume, and that's a volume amount. How much is your lungs full? So if you had a baby, the volume would be very, very small compared to an adult because it's much bigger lungs. The inspiratory pressure is how much pressure does it take to fill to that tidal volume. So how much pressure? So if you have really, really stiff lungs, it's going to take more and more pressure to open up the lungs. So you would have a higher PIP. you run risk with higher PIPs for damage to the lungs. So that's an important number to know. PEEP is the peak expiratory end pressure. So this is how much pressure is left. How much pressure does it take to keep the lungs somewhat open? So you don't want them to collapse all the way down, because if you have the alveoli collapse and close, you can't open it back up very well because of mucus and everything that makes it stick together. So you want a little bit of air in the lungs after you exhale. And that is your PEEP. That's the amount of pressure that it takes to keep your lungs sort of open so that they don't collapse down on themselves. So when we take a breath, it comes from the brainstem. So the brainstem is getting impulses throughout the body from chemoreceptors, and those chemoreceptors are picking up how much CO2 is in the blood. And then that goes to the brainstem. The brainstem is getting those transmitted impulses from the brain, from other chemoreceptors in the body, and it sends a neural impulse to take a breath. Now, obviously, it's involuntary. We don't think about it. I mean, we can force ourselves to breathe. As I'm talking here, I feel myself breathing faster, but um, we don't think about it, right? It's just something our body does. So we don't have to think about it, because if we had to think about it, we would be consumed with that, right? So then that triggers the medulla, and the medulla sets the rhythm of how fast you're going to breathe. And this is sent by the ventral respiratory group. The dorsal respiratory group receives afferent impulses from the neurosystem to the chemoreceptors, and that changes your pattern based on oxygen level and CO2 level. Most of what a healthy person, CO2 is driving your breathing. So, however much CO2 you have in your blood, that then will cause you to breathe faster, deeper, those kind of things. If you have a chronic lung disease where your CO2 is always sitting high because your lungs don't do a very good job of getting rid of it, it will switch over to O2. So how much O2 you have in your blood will be your drive. With that switch, you need to know that. So if somebody comes in with a chronic lung condition and you do an oxygen saturation of them, which is, your pulse oximetry, that is a screening. That's just a screening. And we're going to talk about that in just a minute, but it's a screening. So if you have somebody who comes in and they have chronic lung disease, you put the oxygen saturation on there and it's low, well, their drive to breathe is oxygen. So if you give them oxygen, then you drop their drive to breathe. So keeping that in mind. But for healthy people without lung disease, it's CO2. So your breathing drive, so you have chemoreceptors and they pick up the change of carbon dioxide in the CSF fluid that passes through the blood-brain barrier. So then the CO2 binds with water to make carbonic acid, and that gives off your hydrogen ion, and that lowers the pH of the blood. This stimulates the respiratory center to increase the breathing rate because um, the CO2 is too high. You have all this carbonic acid, so you have a high hydrogen ion. So you want to lower the amount of CO2. So that stimulates your breathing center, so you breathe faster and deeper. Again, like I said, over time, we talked about, if I'm sure you talked about in nursing school, compensation. So if over time the lungs are not compensating by breathing faster, then over time the kidneys will start to retain bicarb. Bicarb, then the hydroxyl ion, which is OH negative, binds with the hydrogen ion to make water, neutralizing your pH. But then you have CO2 left over, so it makes even more CO2. So we don't like to wait for the kidneys to do it because your CO2 will go up even more. So your pH will normalize, but your CO2 will be higher, and that's when you get into trouble with that. So the chemoreceptors, you have some in the aorta, and they're very sensitive to the CO2 and the pH, but they're very sensitive to oxygen as well. So as your oxygen and your pH decrease, they send signals to increase the breathing rate. The lung receptors, you have several. You have the irritant receptors. They're very fast adapting. So the epithelium of the lung tissue is in the conducting airways, and it's sensitive to gases, dust, anything that could make an irritant, basically, to your lungs causes you to cough. And that cough then forces out whatever is irritating it, plus any mucus, um, water, whatever, and you get this lovely picture here. So stuff's just spewing when you cough. This, if you think about a cough is never normal. Always remember that. A cough is never normal. You're coughing for a reason. You're trying to get something out of the upper airway or out of the lower airway. It has triggered that cough. Um, so sometimes we'll have patients where they want something to lessen the cough, which, coughing can become very, very irritating. But it's your body's defense to get rid of whatever is in the lungs or trying to get in the lungs. There's stretch receptors. These are slow adapting. So this is in the smooth muscles of the airway. So if they're stretched, they decrease ventilation rate and volume. So if you have a lot of air building up in there, you don't want to put more in there. So it decreases how deep you breathe and how fast you breathe. And then we have pulmonary C fibers, and these are in the capillaries in the alveoli septa, so in the little tiny air sacs. These increase your capillary pressure. It stimulates rapid, shallow breathing. It causes laryngeal constriction, mucus secretions, hypotension, and bradycardia. So these, if they are stimulated, will cause a lot of changes in the lung tissue. So, what keeps our lungs inflated? If you think of it like a balloon, that's what the only analogy I can think of. If you think of it like a balloon, if you blow into it, it expands, and then if you have no more air going in, then it will collapse down. But we don't want it to collapse on itself because if it collapses on itself, it's very hard to get back open. Think of like a really, really difficult balloon and you're putting all this pressure just to get it to open. So what makes that, so what's causing that really stiff is the surface tension. So we want to decrease the surface tension so it's more elastic, easier to breathe. So that's surfactant. Surfactant is in everybody's lungs. It's kind of a milky fluid. It decreases the surface tension of the tissue, so it's easy to stretch the tissue and have it go back to the normal shape. So it's not overstretched. So this surfactant then lowers that surface tension. It's produced in the alveoli cells. And again, like I said, it prevents the collapse, makes your lungs easier to breathe. There are some things that inhibit surfactant production. If the surfactant production is inhibited, then the lungs become very, very stiff. And that tissue becomes very, very easy to injure. So if you think of that balloon analogy that I'm blowing into the balloon, I'm stretching out the alveoli, and if I put a lot of force, sometimes the balloon's going to rupture, right? It's just going to pop. Or if I put too much air in, I keep blowing, 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 and I don't let it go out, it will rupture, it will pop. So think of that with your alveoli too. If you can't get air out of the alveoli and you just keep putting more and more in, it will pop. If you don't put enough in, it will collapse. If you if it's really, really stiff and you force air in, it will pop. So that's what happens also with alveoli. So gases that are important to us, For us, the partial pressure of oxygen in the air is 21%, and that's what we need. That's what we take in. We obviously can do higher amounts of oxygen. Oxygen is a free radical, though. It's not what you would call the cure for everything. It can cause tissue damage if you have too much. So it's not something that we want to put everybody on oxygen. But, adults obviously can handle it better. But long periods of oxygen exposure can cause tissue damage. Also, remember, water vapor comes from your upper airway. So if you breathe in air, and air is relatively dry, except in the summer months here in Northwest Indiana. But if you breathe in air, your nose and your mouth provide vapor for that air to go into your lungs. If you breathe in really, really dry air, then you start to make a bunch of mucus. And if you make a lot of mucus, you're going to cough and you're going to block off airways and it's going to be a problem. So we want that vapor. So think of that for patients that have a trach, where the air comes in at the neck. They're not getting that moisture from the upper part of the airway. So they usually have to have that humidified at least for part of the day or something, or their body gets used to it. But it really, moist air is best. Also, in the upper airway, it's warmed. If you're in a hospital, if you take oxygen from the wall, it's liquid oxygen, so it can be stored easier. And it's cold. It's really, really cold. And if you breathe in cold air, what do? You go, "Ugh." Think about it, those January mornings when you walk outside, it's, 20 below, you're like, "Ugh." You just kind of gasp. You have a gasp reflex from that. So we want the air to be warm because it's going into your body. And if it's cold air going into your body, that makes you cold. You're internally putting something cold inside of you. So your body has to work extra hard to warm it up, uses more energy, which, a sick patient may not have. We obviously exhale carbon dioxide. Most of the remaining air is nitrogen. For nitrogen, we just breathe it in and then we breathe it right back out. But that is what is most in the air is nitrogen. All right, so the oxygen dissociation curve. So if we talked a little bit about oxygen saturation. So oxygen saturation is a screening. It's not diagnostic. Screening. But you can't continuously draw arterial blood from a patient because they'll start to need that blood after a while. And there have been equipment out there that I don't know, don't work with adults or anything, but we used to have a machine that you could pull out a blood sample, it would analyze it and put it back in the body. And we found it wasn't, or we even had a sensor inside of the body to measure gases. And we found that it wasn't super helpful. Not super helpful because you had to get it in the exact place in the body to measure it. So um, sometimes they're accurate, sometimes they're not. So, and they're expensive. So usually we do the screening with the oxygen saturation. Now, oxygen saturation will change depending on what's going on with the body. So if you look at an oxygen dissociation curve, you have the oxygen saturation here. That's how saturated the blood is with oxygen. And then you have the oxygen partial pressure. How much oxygen is actually in the blood? Not it's what's saturated in the cell, but how much oxygen do we have readily available for the tissue? And that, again, you need to know from the arterial blood gases. But we can get a general sense of what it is by doing the screening with the oximetry. So for the oximetry, if you have a normal pH for a healthy person like you and I, it is right here. And you'll see it's pretty much correlated. So obviously, if your oxygen saturation is 40, your PO2 is like 20. So it's pretty not super accurate, but it tells you it's low. It tells you it's low. And that gets to be about here to about 95%. So 95% you see it flattens out. So if we have an oxygen saturation of 98%, so 98% I would say is about here. Well, it's also almost all the way over here too. So we could have a PO2 of 80, or we could have a PO2 of 200. Now, we don't want a PO2 of 200. Remember, we talked about our oxygen dissociation, or our oxygen is a free radical. It causes damage. We don't need those high oxygen levels. And we certainly don't need those high oxygen levels in a patient that has chronic lung disease because that's their drive to breathe. So we don't want that. So for those patients that come in the ED or come into your office and they don't look so good and they're having trouble breathing and they've had chronic lung disease and you put that oxygen saturation on and it says like it's 91 and you don't like that number, so you give them oxygen. They're going to stop breathing on you. You don't want that. 91 is okay for those patients because 91, if we look here, it's low, but they've been probably reading that for a long time. They probably are reading that. And now oxygen is their drive to breathe. So if you give them oxygen, they stop breathing. Now, there's some things that move that curve. So if we have an alkalotic patient who has not much CO2 in their blood, so hypocapnia, their oxygen dissociation curves to the left, comes to the left, it deviates over here. So that moves our curve here. So if you look at this, if their SAT is 40, what's their PO2? It's even lower. It's even lower. So keep that in mind. If they're acidotic with high CO2, what does that do to their curve here? It moves it to the right, and you have this right shift. So what does that tell you? So we have our patient who comes in, chronic lung disease, too much CO2. So now their drive to breathe is O2. So they're now on this curve and they have a PO2 or sorry, oxygen saturation of 90. And that's here. What's their O2 level? It's pretty good. It's pretty good, right? It's a pretty good number. Now, is that where we want to set them? No. Obviously, we've got some acidosis causes a lot of other issues, but when we don't want to just give them oxygen because if we give them oxygen, then they're gonna stop breathing. So remember that the more acidotic you are, it moves it to the right. You can have a lower SAT with higher PO2s. It does the same thing also with not just pH, but your temperature. So if you are cold, it moves it to the left. If you are warm, it moves it to the right. But this is where I really want you to look here. So if you've got those patients who come in chronic lung, high CO2, their oxygen dissociation curve has moved to the right. So it doesn't take much to get their PO2 up, but we don't like the acidosis either because there are other things that are going to be a problem. So just some terms that we use in respiratory. Dyspnea means they have difficulty breathing or painful breathing. A cough, again, is a reflex to clear the airways. It's an explosive expiration. If you sneeze, a sneeze is to clear the upper airway. So you're sneezing and that's forcing air out the nose and mouth at a very accelerated rate. And so usually it's the trigger for a sneeze is something that hits you like an allergen or something like that in the upper airway to make you sneeze. Lower airway is a cough. So you might do both if you're sick, with your respiratory infection or whatever, you might do both. But a cough, never normal. It's never normal. There's something in there that you're trying to clear. Sputum, terrible word, secretions in the airway. Uh, Eunipnea is normal breathing. Kussmaul respirations, you have an increased rate, you have a large tidal volume, no expiratory pause. This is not good. Obviously, this means you're very, very sick. Cheyne-Stokes respiration, this usually happens around death. It's caused by poor blood flow to the brain. So you have alternating deep and shallow respirations because you're getting different signals into the brain. The brain is not functioning like it should, so you're not having that brainstem medulla um, kind of triggers to help you breathe. Hypoventilation means you have decreased minute volume, and hyperventilation is where the alveoli ventilation exceeds your needs. So you're blowing off too much CO2. Again, if you do that for very long, remember our respiratory drive is CO2. You blow it off too much, you'll pass out because you're not breathing. Clubbing is where you have, and this isn't kind of an extreme case here, enlargement of the distal end of the fingers or toes. It's painless. It develops over weeks, so it's not something that just happens overnight. It's caused by chronic hypoxemia, and it's rarely reversible. But you can see, this is a sign of a chronic low oxygen levels. Hypercapnia, that means that you have too much CO2 in your blood. Hypoxemia means you don't have enough oxygen in your blood. So with hypercapnia, it's caused by hypoventilation, depression of your respiratory drive, diseases of the medulla, abnormal spinal conduction pathways, diseases of the neuromuscular junctions, problems with the thoracic cage, obstructed airways, increased work of breathing, or physiologic dead space. So physiologic dead space means that the breath that you're getting in, um, there's too much of a pathway for it to get in, so it loses its oomph by the time it gets down there. We see this a lot with patients on endotracheal tubes. If you have an endotracheal tube that is too long, then they call that the dead space, and the breath loses its oomph before it gets down to the lungs. Hypoxemia, this is low oxygen in the blood, and this is caused by decreased inspired oxygen, hypoventilation, ventilation perfusion mismatch, abnormal alveoli capillary diffusion, and decreased pulmonary capillary perfusion. So not enough blood getting to the capillaries of the alveoli to have a good gas exchange. So some of the structural problems would be a pneumothorax. So pneumothorax is free air in the pleural space. So it's free air outside of the lungs. So if you look at this X-ray, this is kind of a bad chronic lung X-ray here. You can see here this dark area here. And you can kind of see it makes a bubble around. That is free air sitting up on top of the lungs. It collapses the lung tissue down. So this is usually due to some kind of damage to the alveoli. They've ruptured. So now every time you take a breath in, air goes out of the lungs, outside of the lungs. And the more it builds up, the more it compresses the lung tissue. Now there's a little bit of give in the thoracic cavity, not a lot though. And there's a little bit of give in the diaphragm, not a lot though. And so at first they'll be uncomfortable, but then as it progresses, it's going to get more and more difficult for them to breathe. And so they're going to breathe faster because that's what the brain's telling them to do. But as they breathe faster, it makes the pneumo worse. So it could be primary, so it just ruptures. Some people that are more at risk for a pneumothorax would be really tall people with a large thoracic cage. They are prone to these spontaneous pneumothoraces. Secondary is caused by injury. So something has caused the alveoli to rupture, something has entered the cavity because you know it's kind of a vacuum in there. So if you have an injury where it's coming through your thoracic cavity between the ribs or with the rib, maybe your rib has punctured the lung, and it comes in, it damages the lungs and opens a hole. But you also have air from the atmosphere being pulled in every time you exhale. It's sucking air from the outside in, and that's making it worse. Pleural effusions is fluid in the pleural cavity. So this is fluid outside the lungs between the thoracic cavity, you have your pleural space, then it's filled with fluid. And this x-ray you can see it's got fluid all through here on this right side. You'll notice here, this is the trachea, and it is really dilated. It's dilated a lot. So this person is trying to get air into this lower side here on the right side, the right middle and lower lobes, it looks like, and it can't. So you see the bronchus here is really dilated too. And that's just air being forced in. If you look at this right upper lobe and this left side, this is really dilated. So they're getting air into the tissue that can expand, and you're getting a lot of air in there, but they're not getting any air down here. So even though they're pulling as much as they can here, it's not really working. And this could be due to lymphatic drainage. So, fluid in the pleural cavity drains into the lymph system. And this is kind of where the exchange of lymph fluid coming out of the bloodstream goes, is right by the lungs. So if you have any damage to the lymph system, say you have an infection or something, and the lymph system becomes clogged, then it will back up around the lungs. It could be pus, which is empyema, blood, which is a hemothorax, chyle fluid. The chyle fluid is basically the lymph protein kind of fluid that comes from the lymph system, and that's called a chylothorax. So chyle fluid is in there. Transudative effusions, so kind of a watery infusion, and this you'll see with congestive heart failure, liver, kidney disorders. Exudative effusions, this is where, we've talked about exudate, where it's a response to inflammation. It's where all the white blood cells are arriving, all those fluids, those anti-inflammatory, or I'm not, sorry, not anti-inflammatory, but inflammatory response leaks in, and it kind of opens up those capillaries, and then you have inflammation, leads to infections, or even a malignancy can cause this. Empyema, again, is infected pleural effusion. Restrictive lung disorders, this causes decreased compliance of the lungs. So you can have, this could be caused by aspiration. So fluid or particles are aspirated or pulled into the lungs, and that leads to pneumonia or pneumonitis. So if you look at this picture, you see this patchy area here. This is a bad pneumonia. Right upper lobe is very common to have a pneumonia here. It's a smaller lobe. If you aspirate anything in, the right bronchus sits higher than the left bronchus, so it goes to the right side, and the first bronchiole coming off of the bronchus is that right upper lobe. So the first place that aspiration goes is this right upper lobe. So that is typically where you're going to see aspiration if it's not everywhere. Pneumonitis is not pneumonia per se, but it's an inflammation of the lungs. Atelectasis is collapse of lung tissue, and so sometimes atelectasis and pneumonia look the same on an x-ray. So sometimes, especially that right upper lobe again, is probably the first place to collapse. This can be caused by compression, so some kind of external pressure, so maybe a tumor enlarged heart, something like that. Absorption, so a gradual absorption of air because of obstruction or hypoventilated alveoli. So if you can't get air into an alveoli, say you have an infection and you have a bunch of mucus there, and you take a big breath, you can push through that mucus, but then you can't exhale it back out. So sometimes it'll get stuck in there, or sometimes you can't even push through, and that causes atelectasis. Or surfactant impairment. So because of some disease process, you don't make surfactant, and therefore the lungs will collapse down on themselves. Bronchiolitis, this is inflammation in the small airways, so the small bronchioles. Um, the smaller the patient, the more difficulty they have with this. Typically, it's a viral infection, RSV, respiratory syndactyl, um, I'm sorry, syncytial virus is the cause, and that will cause a lot of mucus, a lot of mucus. If you ever had RSV, you have a lot. And it's deep inside the lungs, so you're coughing a lot. And it's hard to get that mucus to break up and come out. It can cause permanent damage to the lungs, especially at those little alveoli. We do not give bronchodilators. That is not the problem. The bronchioles are fine. They're opening up. It's the alveoli. The excuse me, the little tiny bronchioles are so full of mucus that you can't get air past them to get into the alveoli. So that leads to atelectasis. It can lead to rupture of the lung tissue and pneumothorax. And typically, what happens is it will lead to pneumonia. So, we don't give antibiotics for RSV per se, it's a virus. But if it doesn't get better over, usually after 5 days, if it's getting worse, um, we might go ahead and treat with antibiotics because right now you probably have moved on to pneumonia. So, for a long period of time, if you have it, um, and you're developing other signs of infection like a fever and all of that, then they'll probably treat you for pneumonia. Pulmonary fibrosis is where the tissues now become fibrotic. Fibrotic tissue is never functional. It's basically scar tissue, and it's not going to work the same, but it will take up the same space. And this is usually due to chronic inflammation, or some disease processes like cystic fibrosis. Once the fibrotic tissue or once the lung tissue becomes fibrotic, your prognosis is poor. That tissue is useless. So you might need a lung transplant or that tissue removed. Pulmonary edema is excess water in the lungs. We'll see this with left-sided heart disease. So you have increased pulmonary venous pressure. We're going to talk about that a little bit. Injury to the pulmonary capillaries. You can have ARDS, which is acute respiratory distress syndrome. This is lung inflammation and diffuse alveolar capillary injury. So the lungs are so inflamed that they're not working properly. This is usually caused by an acute immune cell-mediated injury to that alveolar capillary membrane where you have the gas exchange. You have massive inflammation, increased capillary permeability, so leaking of fluid. The alveoli become flooded, and then you have pulmonary edema. And during the proliferation stage, it will lead to fibrotic changes. So we already told you that's a bad sign once you get to the fibrotic tissue. It will also block your lymphatic vessels so they won't drain properly, which again leads to fluid building up around the lungs because that's where you have that exchange of lymph fluid. So heart failure, it can be left-sided or right-sided. And you're like, well, this is the heart, not the lungs, but it affects the lungs. So this is where the heart is unable to give an adequate cardiac output. So that leads to inadequate tissue perfusion. So you're not getting blood out through the aorta, decreased perfusion. So you have increased diastolic filling pressure on the left side of the ventricle or left ventricle. And then you have increased pulmonary capillary pressure. So the left side is most common. We call this congestive heart failure, although I think Congestive has been dropped. I think we just call it heart failure now. And this is where you have reduced ejection fraction, so not much blood coming out of the heart. And then, as you know, the left ventricle is where the blood is being squeezed to go out the aorta. You have ventricular remodeling so that myocardial tissue becomes dilated. So you have increased preload. You have, because you don't have much blood coming out, you have decreased renal perfusion. Well, again, the kidneys, they have not treated us well, right? Sometimes they're not helpful. If you don't have good renal perfusion, then the kidneys think, oh, we have poor blood pressure. So what does it do? It goes to that renin, angiotensin 1, angiotensin 2 to increase the blood pressure. Well, if you increase the blood pressure, what does that do to the heart? It makes it become more tired. So then you can have left-sided failure with preserved ejection fraction, and this is caused by hypertensive induced myocardial hypertrophy, so enlarged heart. Um, like I said, once you get to the kidney perfusion, then it will increase the blood pressure, which puts more strain on the heart and does not help things at all. Right-sided occurs with lung disease, so the blood can't get into the lungs because of its perfusion into the lungs is very poor. So can't do gas exchange. And then it will back up into the right side of the heart. Well, if it backs up into the right side of the heart, where's it going to go? It goes to the right atria and then into this vena cava. So then if you have an enlarged vena cava, vena cava goes right through the liver and the spleen. So if you have backup of blood into the vena cava, it backs up into the liver, the spleen become enlarged and gorged with blood. So sometimes the left-sided heart failure can lead to the right-sided heart failure as well. And then you have that hepatosplenomegaly, and then you're in bad shape. So remember the flow of blood. We've talked about this when we did the heart. It's coming in the vena cava here, into the right atria, into the right ventricle, and then into the lungs. So anytime that can't get into the lungs, it's going to back up in the least resistant, and that's here, back through the pulmonary artery, right-sided ventricle, right atria, back out into the vena cava. Left-sided, the left side of the heart is stronger because it has to push blood at a much farther distance. So if you have this part of the heart failing and then or blood backing up through the aorta into the left ventricle, then it backs up blood into the lungs. So with heart failure, you kind of see here, your left side, it becomes very dilated with that blood because it can't get into the lungs. So it dilates up the left side, less coming out of the aorta. It's going to back up in the lungs. Then once it backs up into the lungs, it backs up eventually into the right side of the heart and then out to the rest of the body. Obstructive pulmonary disease, this is where the airway obstruction is worse with expiration. So as you try to exhale, something's narrowing that so you can't get rid of the air. So you need high levels of force to exhale just to empty your lungs. This usually is due to an inflammatory process. Usually it releases those cytokines, which we talked about before. And this causes dyspnea or difficulty breathing or painful breathing. And because those airways are narrowed, it causes wheezing. The air is kind of whistling through that narrowed area. And this can be caused by asthma or COPD or chronic obstructive pulmonary disease or chronic bronchitis, emphysema. So let's talk about that first, chronic obstructive pulmonary disease. So air limitation is not fully reversible. It's usually progressive. So it gets worse and worse and worse. It kind of starts out with chronic bronchitis. So you have hypersecretion of the mucus, chronic productive cough. I was at a uh, conference the beginning of the week, and there was a woman there with a cough that was horrible, horrible. And I was just like, oh my gosh, you need some help. But anyways, and that can continue for at least 3 months. out of the year for the past 2 years is how we diagnose chronic bronchitis. So you have inflammation and thickening of the mucous membranes, and so you have a lot of mucus, a lot of pus, just a lot of sticky stuff that you can't get rid of. So just a frequent cough. And it's a heavy cough. And sometimes you'll even hear it's productive where you actually hear the mucus come up. Emphysema then is abnormal permanent enlargement of the gas exchange airways with destruction of alveoli without obvious fibrosis. So this is the next step of that chronic fibrosis where it's even more difficult to breathe. You have more narrowing of the airways. Causes can be tobacco smoke or air pollution causes irritation, inflammation in the airway epithelium. Then your inflammatory response goes haywire. It increases protease activity. So remember, proteases are breaking down proteins, and they break down elastin in the connective tissue. And so your lungs are not real elastic, easy to breathe. And that destroys your alveoli septa. And then you have loss of elastic recoil of the bronchial wall. So you can't, to get air in out, your lungs are really stiff and you can't move the air as well. So if you look at COPD, you have the healthy airway, and then over time you get this excess mucus and inflammation, and then that leads to the breakdown of the alveoli. Again, some of the signs and symptoms, shortness of breath because you can't get the air in or out, productive cough, wheezing, weight loss because you're using so much energy to breathe. Your chest will become enlarged because of that increased muscle it takes to move the lungs and limited physical activity because you just can't get the air in to that you need, that oxygen that you need for energy. Causes number one, cigarette smoking, exposure to chemicals, chronic diseases like cystic fibrosis, or some genetic abnormalities. We usually treat with bronchodilators. Bronchodilators will help some, but if the tissue is not elastic, it's not going to move much with bronchodilators. Steroids will decrease the inflammatory response, so you don't have quite as much mucus. You might need oxygen or even like CPAP to get the air in. And of course, you're more at risk for respiratory disease, so make sure that they get their vaccines. The worst thing, if the left side becomes failure and it moves over then to the right side, then that's right ventricular hypertrophy, and that leads to cor pulmonale. So that endothelial dysfunction causes an overproduction of vasoconstrictors and decreased vasodilators. And so you don't, again, that's going to your kidney, right? The kidney is causing that vasoconstriction because it doesn't get a good blood flow. And so it causes vasoconstriction to increase your blood pressure. Let's put more strain on your heart. So more strain on your heart, it tries to work harder, but it can't. So then the blood will back up into the lungs, which backs up into the right side of the heart. So then this right side has to work super, super hard to get blood into the lungs. And because of that, it becomes hypertrophied or enlarged. And because of that, it causes increased workload in the right side, and then this side will eventually fail. And if the right side fails, then both sides have failed, right? The left side we already know has failed, the right side's failing, and that's called cor pulmonale, and that is not much you can do. We need a heart transplant, basically. Pulmonary embolism is where you have occlusion or partial occlusion of the pulmonary artery or branches, and if blood sits there and doesn't go anywhere, it makes a clot. And if it has a clot, it could be a clot there, it could be a clot anywhere in the body. It comes in to the lungs because we're sitting there, blood is coming returning to the heart on the right side. It goes into the right side, and where does that go? To the lungs. And so you have capillaries then in your lungs, smaller vessels in the lungs, and that's where it's going to get stuck. So It can be tissue fragments, it could be a fat emboli, it could be a foreign body, air embolus, amniotic fluid, or blood. And then again, that's going to cause that clot formation, causes the occlusion. So then you have hypoxic vasoconstriction and decreased surfactant production. You have increased inflammation, causing that pulmonary edema and then atelectasis. So extremely difficult breathing. Asthma. So know that you've probably studied asthma as a nurse. Asthma is an inflammatory process. So usually you might have reactive airway disease. That's what we call it when little kids have it. So there's some kind of trigger or some kind of factor, and that causes atopy so that it just makes it hypersensitive to that trigger. So, a lot of things bother a lot of people, but for asthma, it really bothers them. And so it's a hypersensitivity to whatever that trigger is. So when you're first exposed to it, you sensitize your T cells, which stimulate your beta cells to produce IgE. And we'll get into inflammation and inflammatory response a little bit later. But that binds to your mast cells, which we've already talked about mast cells, and that activates your T cells and your IgE sensitive mast cells that line the airway. So now your body is hypersensitive to whatever comes in, that whatever that triggers there. You already have your T cells, your IgE all ready to go. And so a second exposure from that trigger, early response usually happens within the first 2 hours. You have your allergens that cross-link to the IgE or mast cells, and they release histamines. Histamines, not always our friends, leukotrienes, and other inflammatory mediators. And we've talked about these. They increase vascular permeability, so you have more fluid getting to the airway mucosa. Your goblet cells, they produce mucus, so they become hyperplastic, so they enlarge, and you have even more mucus. And the bronchial smooth muscle contracts because it's trying to block whatever triggers coming in from into the lungs. So you have a lot of fluid, so that causes edema. You have the mucus, and then you have pulmonary constriction. And that causes an obstruction, and that leads to asthma. So very difficult getting air in and out. So the delayed response, whatever the trigger was, it activates your mast cells again and your releases cytokines. And we've talked about cytokines. It induces the maturation of the white blood cells. And we talked about eosinophils, basophils. Those are what you're going to see for this response. Those are allergic or asthma or parasites will do it too. But eosinophils and basophils you're going to see. These migrate then to the site of that trigger. Again, you're going to have constriction. It also causes pulmonary dilation in your eyes, so your eyes become red, lots of fluid there, so your eyes water, your nose runs, it's, that fluid getting to there by the increased permeability and also mucus production, so you have a runny nose or rhinitis. So those are other symptoms of asthma. So any trigger for asthma could be an upper respiratory infection, allergens, air pollution, cigarette smoke, other chemicals, certain drugs can cause it. Asthma can be triggered by cold air or even exercise. So treating asthma, we have to treat it with medications that's going to open the airway. So bronchodilators will open the airway so that you can remove mucus and cause more air exchange. When we talked about RS3, remember we're talking about the little tiny bronchioles, so it's not going to dilate those open. So, but bronchodilators for RSV or any kind of bronchiolitis does not work. Asthma, it does work. You can use the long-acting beta-2 agonist bronchodilators. These are for longer periods of time. So usually our typical bronchodilator you think of as albuterol. It lasts for a while, but then it has a short half-life. These long-acting ones have much longer half-life, so you don't have to take them as much. Glucosteroids, that decreases that inflammatory response. Uh, muscarinic antagonist are anticholinergic, so that blocks acetylcholine. And acetylcholine will cause bronchoconstriction and increase mucus production, so it's blocking that response. Leukotriene modifiers, leukotrienes, they cause bronchoconstriction, increased mucus production, that whole inflammatory response again, and over time will cause airway remodeling, which can lead to fibrotic tissue. So the leukotriene modifiers will um, stop those leukotrienes from causing all those problems. And then there are biologics, and these biological, it depends on the cause of the inflammation in the lungs. There's several different ones out there. So whatever pathway they believe to be causing this inflammation, the biologics will block those pathways. So that is all I have for you. Let me know if you have any questions. Have a good day.